as a very basic principle, the transition to ICD-10 does not in any way change the current use of the CPT and HCPCS code sets, and there's actually been some confusion out there about that. But everyone will have to implement the ICD-10-CM diagnosis code set, but only hospitals will use the ICD-10-PCS code set for reporting of hospital inpatient procedural services. CPT and HCPCS will continue to be used in the outpatient setting and for physician reporting. And ICD-9-CM and ICD-10-CM, as you will see shortly, are very similar. There's a lot more specificity in ICD-10-CM, but the structure is very much the same. A lot of the conventions and instructional notes are very much the same, but ICD-10-PCS is a different animal entirely. So next slide. We'll just briefly cover what some of the key benefits are of moving to ICD-10. It is a major transition, a major complexity to move to a new code set, but we've been with ICD-9 since 1979, and I'm sure all of you are aware there's been a lot of changes in medicine since 1979. So ICD-10 is much more clinically relevant to today's environment. There's a much better reflection of clinical severity and complexity, more accurate representation of provider performance, less ambiguity. A lot of people think, well, if you have a lot more codes, a lot more specificity, it makes the code set more complicated to use. But actually, particularly as you gain familiarity with it, the opposite is actually true. The more specificity and detail you have in the codes, the easier it is to select the most appropriate code. The better detail helps to support medical necessity, helps to validate physicians' evaluation and management coding, provides more accurate and fair reimbursement, not necessarily more reimbursement or less reimbursement, but at least it can represent it more accurately. And it permits less misinterpretation by auditors, attorneys, and other third parties just because the specificity makes the coding more black and white. Next slide. A few more benefits are that it improves efficiencies and actually ultimately, once you get past the learning curve, lowers administrative costs because the increased detail means that payers and other third parties are getting more information just in the codes themselves and don't have to request manual medical record documentation to fill in the gaps that the current ICD-9 codes have. Due to the increased specificity, these codes will more readily support medical necessity of diagnostic testing as well as therapeutic treatment. And as I mentioned, fewer coding errors actually, due to less ambiguity in the code titles and more up-to-date terminology that's more consistent with physicians' terminology. The increased specificity allows for expanded use of automated tools to facilitate the coding process, which improves the administrative use of the code sets and increases productivity as well as accuracy. Next slide. Now we're going to spend some time focusing on each of the code sets, and the first one we will talk about is ICD-10-CM. So next slide. So here's a comparison of the structure of the ICD-9 codes versus the structure of the ICD-10-CM codes. So the ICD-9-CM diagnosis codes, as you all know, has 3 to 5 characters, whereas ICD-10-CM has 3 to 7 characters. In ICD-10-CM, the first character is always alpha, and all letters except the letter U are used. The second character is numeric, and then characters 3 through 7 are alpha or numeric. So you can see that helps really make the system much more flexible than the ICD-9 code structure. There is still a decimal after 3 characters, just like in the ICD-9-CM diagnosis codes. And one important point to keep in mind with the alpha characters, they are not case sensitive. We get that question a lot because they're often portrayed in uppercase, so people think that it has to be an uppercase in computer systems and databases and so forth, but they're not case sensitive. There is no meaning between showing a lowercase letter or an alpha case or an uppercase letter, as I've shown in these examples with the alpha characters. Next slide. There are a lot of similarities in ICD-10-CM compared to ICD-9-CM. So, for example, there's still a tabular list containing a chronological list of codes that are divided into chapters based on the body system. There's the same hierarchical structure that we currently have in ICD-9. And the chapters are structured very similarly with a few minor exceptions. A few chapters have undergone some restructuring, and the sense organs, the eye and ear, have been separated from the nervous system chapter and moved to their own chapter. Next slide. The index also has a lot of similarities. It's still an alphabetic list of terms and their corresponding codes. The indented subterms appear under the main terms. The structure is very much the same. There's an alphabetic index of diseases, an alphabetic index of external causes, a table of neoplasms, and a table of drugs and chemicals. Next slide. Many conventions also have the same meaning. There's still a lot of the same abbreviations, punctuations, symbols, notes such as code first and use additional code that we're all familiar with in ICD-9. There are also still unspecified codes in all of the categories. And codes are pretty much looked up the same way. You look up the diagnostic term and the alphabetic index, and then you verify the code number in the tabular. On the next slide, a few more similarities are that, just like in ICD-9, the codes are invalid if they're missing an applicable character, and we'll talk about some of the differences in some of the final characters that we'll find in ICD-10-CM. There is still a set of official coding guidelines that accompany the ICD-10-CM code set, and adherence to those guidelines is still required under HIPAA, just as it is under ICD-9. So on the next slide, let's talk about some of the differences from ICD-9-CM. Well, a lot of the major part of the difference is in the expanded detail and specificity, which came about from a lot of significant public input, including many physician groups that felt that more specificity would be necessary in order to accurately measure quality of care, distinguish severity levels, evaluate patient outcomes, and basically support all the health information demands that we're seeing in today's world. Laterality, which is a huge part, obviously, of the injury section, is one of the biggest changes in ICD-10-CM and one of the biggest, actually the biggest reason for the increase in number of codes. It actually accounts for about 46% of the increase in the codes is just from laterality. The codes better reflect modern medicine and updated medical terminology. Even though we've updated ICD-9-CM every year since it was implemented, just its limited structure and the limitations we have with the World Health Organization's version of ICD-9, we could only do so much to really update ICD-9 to a certain point, and then there's just still a lot of outdated codes, a lot of outdated thought processes with a lot of the medical conditions, and so that's all been updated in ICD-10-CM. One area that all of you would be interested in is that the injuries have been regrouped so that they're grouped by anatomical site rather than type of injury. So whether it's a sprain or fracture, etc., they're all together according to the anatomical site rather than starting with the type of injury. There are a lot of expanded use of combination codes in ICD-10-CM to help really help the coders, because a lot of times it's been a chicken and egg syndrome under ICD-9 of conditions that commonly occur together, which should be sequenced first, and a lot of angst over that. And this takes a lot of that out of the process and basically puts them together. So a lot of conditions that have very common symptoms or manifestations have been grouped together, and poisonings and their associated external cause have been put into single combination codes as well. So let's start off with some of the key changes we have in the injury chapter. First of all, we have a seventh character, which is a whole new concept. And the seventh character identifies the type of encounter, and I'll go into explaining exactly what that is. Also identifies whether it's a closed versus open fracture, routine versus delayed healing, malunion or non-union of a fracture. So the seventh character describing the encounter, and this area is one of the areas that it takes some getting used to understanding. There's a character for initial encounter, which is defined as being used as long as the patient is receiving active treatment for the condition. And one of the things you have to kind of put in the back of your mind is not get too focused on the word initial. In fact, hopefully after the code freeze is over, there might be some modifications of that word. There's been some suggestions that maybe it should change to active treatment or something like that, because people have been sort of hung up on the fact that you could only use that seventh character for the very first encounter for an injury. But what it really means is if you go to the ED to be seen for your injury and you're referred to an orthopedic surgeon, and then the orthopedic surgeon schedules reduction of the fracture, all of those encounters, as far as the definition of the seventh character goes in ICD-10-CM, meets the definition of initial encounter. So the surgical treatment, the ED encounter, evaluation and continuing treatment by the same or a different physician, all of those encounters, even though they're separate and distinct from one another, are considered in the definition of initial encounter to be part of that character definition. Next slide. So subsequent encounter is for all the encounters after the patient has received active treatment of the condition and is just receiving routine care for the condition during the healing or recovery phase. And probably the easiest example to understand for the use of the subsequent encounter seventh character is aftercare. So when you think of all of the V code aftercare codes we used to use in ICD-9, those would all be under subsequent encounter. So cast changes or removals, x-rays to check the healing status, removal of fixation devices, medication adjustments, anything that's sort of beyond the active phase of treating the fracture. Rehab would also fall under this definition as well. And sequela is the same as a late effect in ICD-9. So it would be the complications or conditions that arise later, such as a scar formation that's after the initial injury itself. So on the next slide, I'm going to look at what some of the actual seventh characters look like. So this shows the seventh characters for fractures. And we're going to have some examples later where I'll show you how these seventh characters are applied and what the codes actually look like with these seventh characters. So you can see on the next few slides where we have quite a few different choices. We have initial encounters for closed and open fractures, subsequent encounters for routine or delayed healing, subsequent encounters for non-union or malunion, sequela. And then on the next slide, there's also some fracture codes that get down into the open fracture type 1, 2, or 3, which is based on the Castillo classification of open fractures that I'll talk about in a minute. And then on the next slide, you'll just see a few more examples of some of the types of seventh characters that you will see with fractures. And that letter H, J, K, and so forth, that's the actual value that goes with that description that would be appended to the seventh character position of the ICD-10-CM code. And on the next one, next slide, P through S, just again shows you some more examples of the various choices. Now, not all of the fracture codes have all of these choices. It depends on the type of fracture and whether which ones would be most applicable to those particular types of fractures. So they don't all have this full plethora of choices, but this shows you the full gamut of all of the possibilities. So on the next slide, some key principles in ICD-10-CM regarding defaults are that a fracture not specified as open or closed is classified as closed. Now, obviously, it's better in the documentation if it specifies whether it's open or closed, but if that documentation isn't there, the default in ICD-10-CM is closed. And there are notes within the classification that remind you of this. A fracture not specified as displaced or non-displaced is classified as displaced. And a lot of people find that interestingly or confusing, but it's I think came from the orthopedic surgeons group who felt that, I don't know if maybe more fractures are typically displaced, but we get a lot of questions asking for clarification on this. But the default is displaced. When a dislocation accompanies a fracture, it's included in the fracture code. You don't code the dislocation separately. On the next slide, for a malunion or non-union for which the patient delayed seeking treatment, you assign the seventh character for the initial encounter. And the reason for this particular principle is that the seventh characters for malunions and non-unions are only for subsequent encounter seventh characters. There is no seventh character for initial encounter for malunion or non-union. And that's because originally when the system was designed, it was felt that by the time you were seen for a malunion or non-union, you would have had previous encounters for that fracture already. However, the question has come up about, well, what about a patient that just didn't seek treatment until it had already become a malunion or non-union? So the rule now is that if that's the case, then you don't worry about the subsequent encounter seventh character that specifies malunion or non-union. You just use the appropriate initial encounter. For a code from category M80, which is the osteoporosis with current pathological fracture, you would use that code and not one of the traumatic fracture code for any patient with known osteoporosis who suffers a fracture, even if the patient had a minor fall or trauma, if that fall or trauma would not usually break a normal, healthy bone. All right, on the next slide, we're going to talk about what the Gustillo classification of open fractures is, and many of you may already be familiar with this classification, but it's now been essentially incorporated into the ICD-10-CM system. Now, I'm going to cover what that is here, but really it's up to the physician to document the type of open fracture. And there is a default, which I'll show you later. But this is just to give you a little general introduction of exactly what the Gustillo classification is. So 1 is a wound less than 1 centimeter with minimal soft tissue injury. A type 2 is a wound greater than 1 centimeter with moderate soft tissue injury. And a type 3 is a high energy wound greater than 1 centimeter with extensive soft tissue damage, with a 3A being adequate soft tissue cover, type 3B, an inadequate soft tissue cover requiring regional or free flap, or 3C, involving vascular injury requiring repair. So that just tells you what the definitions of these types are, but again, it's really up to the physician to identify the open fracture type. On the next slide, traumatic brain injuries are captured in category S06, intracranial injury, and they're differentiated by type of injury, concussion, edema, contusion, laceration, hemorrhage, etc. And then they're further divided by specific anatomic site. The sixth character specifies the loss of consciousness with either no loss of consciousness or those time frames that you see on the slide. On the next slide, any associated open wound of the head or skull fracture should be coded separately from the traumatic brain injury code. And again, these principles that I'm going through are either notes within the classification, which both of these are, or they are coding guidelines. So I'm not expecting you to memorize all this from the slides or anything. This just kind of gives you some of the rules of thumb that go along with injury coding. Concussion with other intracranial injuries classified in category S06 should be coded to the specified intracranial injury. So, for example, a cerebral contusion with a concussion would only have the code for the cerebral contusion assigned. No separate code would be assigned for the concussion. One interesting change in ICD-10-CM is that it's incorporated codes for the GLASGOW COMA scale. Now, these are considered optional codes, which obviously trauma registries being one of the areas that might be interested in using them. They're not required, but they've basically taken the GLASGOW COMA scale and converted the narrative description of the scores into actual codes. So there's 3 different subcategory codes for the eye-opening, verbal response, and motor response, for which a code would have to be assigned from each of those subcategories. And then the 6th character identifies, which type of response it is. And then on the next slide, the 7th character indicates when the scale was recorded. So in the field, at arrival to ED, at hospital admission, or 24 hours or more after hospital admission. And this 7th character should match for all 3 of the codes. So on the next slide, this gives you a listing of what all of the COMA scale codes look like. So again, it doesn't actually show you the score number, but it converts the score number to the description of that score in an ICD-10-CM code. And per the next slide, if only the total score is documented, then you use the code from R40.24. But you don't use the total score code if you have information about the individual scores. You just code the individual scores if that's what you know. At a minimum, the guidance for ICD-10-CM is that the initial score documented on presentation to the facility should be coded, but some facilities may choose to capture multiple scores throughout the hospitalization. And non-physician documentation can be used to determine these codes. So this is an appropriate point because typically in ICD-9 and ICD-10 coding, we say the codes have to be based on physician documentation. But this documentation usually comes from non-physicians. So non-physician documentation can be used to determine these codes. So on this next slide, another new feature of ICD-10-CM is a placeholder of X, and this helps really improve the flexibility of the coding system. So it's used in certain codes to allow for future expansion, and it also fills in empty characters when a code contains fewer than 6 characters and a 7th character applies. So this is really an important point because there are some codes that say only have 5 characters, but there is a 7th character such as for the type of encounter that I talked about earlier, that would apply to that code. A seventh character can only appear in the seventh character position. So if the code is shorter than 6 characters, you have to use a placeholder X to fill in the empty slots so that you can append the seventh character in the appropriate spot. And when the placeholder character applies, it must be used in order for the code to be valid. Another change in ICD-10-CM, which I consider a huge benefit, is that it's got 2 different types of excludes notes. In ICD-9 today, it can be kind of confusing because an excludes note can mean either you should never report these 2 things together, or it can mean that the one condition is not included in this other code, and so if the patient has both, you use both codes. And a lot of times there's a lot of confusion about, well, which kind of excludes note is this? Can I use the codes together or not? So in ICD-10-CM, there's 2 different kinds that are clearly defined. So an excludes one note indicates that the code identified in the note and the code where the note appears cannot be reported together because the 2 conditions are mutually exclusive. So for example, at the code for traumatic pneumothorax, there's an excludes 1 for spontaneous pneumothorax. You either have a traumatic pneumothorax or a spontaneous pneumothorax. You wouldn't have both together. So that would be an example of an excludes 1 note. On the next slide, an excludes 2 note indicates that the condition identified in the note is not part of the condition represented by the code where the note appears, so both codes may be reported together if the patient has both conditions. So for example, at S01 for open wound of the head, there's an excludes 2 note for injury of the eye and orbit. If you have an open wound of the head, you could also have an injury of the eye, and it's not included in the S01 code. It's telling you if you also have an injury of the eye, you would code that separately with an S05 code. So now that you've got all of the background in ICD-10-CM in a nutshell and our experts, we're going to walk through a few ICD-10-CM coding examples. So the first one is fracture of the proximal third of the scaphoid bone, left wrist, initial encounter. And by the way, the physician does not have to document initial encounter. You should be able to tell from the documentation that the injury just happened. This is the patient's first visit for this injury, or the injury happened a couple days ago, but they're now just coming in for their reduction. So based on the documentation of the description of the scenario and the chain of events and when things have happened, you should be able to figure out which 7th character for the type of encounter is appropriate. So you start off just like you would in ICD-9-CM, looking up the main term in the index of fracture, scaphoid, and it says to see also fracture carpal navicular. So when you look up fracture carpal navicular, there is a sub-entry for proximal third, and then displaced is in parentheses because, as I mentioned earlier, that's the default, and then non-displaced is a sub-entry. So on the next slide, you see you go to category S62. You see the notes that explain that the fracture not specified as displaced or non-displaced should be coded to displaced, and a fracture not indicated as open or closed should be coded to closed. And then under this category, it will give you the appropriate 7th characters for the codes in this particular category. So on the next slide, we go down to S62.03 because it's the fracture of the proximal third of the navicular bone of the wrist. And then we'll see that it's S62.032 because it's not specified as displaced or non-displaced, so the default is displaced, and it's the left wrist. And then we append the 7th character, A, to show that it's an initial encounter. So that's one example. The next example is a dislocation of the left shoulder, specifically the posterior acromioclavicular joint, presents to the emergency department for evaluation of this new dislocation. So you look up dislocation, shoulder, acromioclavicular. It says to see dislocation acromioclavicular, so you look under that, and there is a sub-entry for posterior, and this is a posterior dislocation. And then in the next slide, you verify the code in the tabular. You look up, you go to S43, which is the dislocation of the shoulder. It shows you the appropriate 7th character to add to the code. And then on the next slide, S43.152 is the appropriate code, posterior dislocation of left acromioclavicular joint. And again, you would add the 7th character of A because this is an initial encounter. So now the same patient has that later encounter for surgical treatment. It's the same code. It's not a subsequent encounter because it's still undergoing active treatment. And then on the next slide, the patient then starts going to physical therapy after it's had the treatment for the dislocation. That would be a 7th character of D because it's no longer active treatment for the injury. But it would, the rest of the code would be the same. It would just be that 7th character that would change. And that's really one beautiful thing about ICD-10-CM. Under ICD-9-CM, we hear a lot of complaints from post-acute settings and from physicians for subsequent encounters that by having to use the aftercare codes, they really lose information about what the original injury was. And so that's always been a criticism of ICD-9. And so ICD-10 attempts to solve that problem by allowing you to continue to use the base code describing the injury and just changing the 7th character to show where you are in the sequence of care events for that particular injury. Okay, let's look at another example, laceration left foot with foreign body. So again, you look the term up in the alphabetic index, laceration foot left with foreign body. You go to S91 in the tabular to verify it. You see that the code is S91.322 for laceration with foreign body left foot. And again, you need that 7th character to identify whether it's an initial encounter or subsequent encounter or sequela. And we're going to assume for the sake of this example that it is an initial encounter still, that it's part of the active treatment for the laceration. So let's look at another example, traumatic subdural hemorrhage, unconscious for 3 hours. And we do have the GLASGOW COMA score, which was taken in the field. So first, let's code the hemorrhage. So look up hemorrhage, intracranial, subdural. It says to see injury, intracranial, subdural hemorrhage. So you look up that term. It sends you to S06.5. So you look that up in the tabular and see that the proper code is S06.5X3, traumatic subdural hemorrhage with the loss of consciousness of between 1 hour to 5 hours and 59 minutes. And in this case, the patient was unconscious for 3 hours. And you need the 7th character to identify the type of encounter. I've shown the placeholder X in this example. And I should note that a lot of the codebook vendors and encoders, they don't make you remember the placeholder X. They automatically show it in those codes that would require it because they have an applicable 7th character. So a lot of coding vendors do show you the placeholder X in the code itself. So the final code assignment then is S0X.5X3A. And so this is just showing you then that same patient and how you would assign the COMA scale scores in ICD-10-CM. And again, while we have the actual scores in the record, you have to convert them to what that means in a description within the codes themselves, and code the 3 different ones: the eyes open, the verbal response, the motor response, and the last digit in these codes reflects where it was taken, which in this case is specified out in the field. So that shows you how the Glasgow COMA scale scores codes would look in ICD-10. And again, these are not mandatory codes. I'm not really sure how many trauma registries are going to choose to use the codes. I've heard a lot of interest in them, but they're considered optional for those facilities that wish to capture this information in this way and have it as part of the clinical code set to actually see what the COMA scale scores are. Here's another example: a stab wound of left upper quadrant of the abdominal wall with penetration into the peritoneal cavity. The tip of the knife broke off and is still in the wound. So you started looking up the word stab. So it does have an entry in the alphabetic index under stab to say, see also laceration. So then on the next slide, you would look up laceration, abdominal wall, go down to the sub-entries for with penetration into peritoneal cavity with foreign body, because the tip of the knife is still in the wound. So S31.629. And then on the next slide in the tabular, you'd actually look at, if you followed through and started with the S31.62, it would show you that S31.621 is really the correct code because it's laceration with foreign body of abdominal wall, left upper quadrant with penetration into peritoneal cavity. And then you need the 7th character again for the type of encounter. And in this case, it, of course, is initial. So it's S31.621A. But this gives you a good example of the kind of detail that you get in ICD-10-CM that you don't get in ICD-9-CM. You get a code here that's laceration with foreign body of abdominal wall, left upper quadrant with penetration into peritoneal cavity, which basically tells you, the vast majority of what the actual diagnosis is, as opposed to some vague, ambiguous, lesser level of detail that we often see in ICD-9. And injuries within ICD-10-CM have among the greatest section of expansion compared to the other chapters. There's a lot of expansion in the injury codes because there was a lot of interest in the injury community in improving this section of codes in ICD-10-CM. So now that you're all ICD-10-CM experts, but at least you can see how you follow the process of getting to the code, that the process is very similar to ICD-9, even though the codes might look a little bit different, and of course we have the type of encounter information that's different than what we have in ICD-9-CM, but still a lot of similarities and comfort level with the process. Next, we're going to talk about ICD-10-PCS, which is a whole different animal from ICD-9-CM procedure codes. But before you become all overwhelmed and intimidated, let me just assure you that what we've seen with training coders on ICD-10-PCS is in the beginning, they're kind of shell-shocked with how different it is. But once you learn the system and you understand the structure and the definitions, it never changes, and people then love it because it makes so much sense and it's so logical and consistent. So So that's how I'd like to reassure you before we move forward and talk about ICD-10-PCS. So on the slide that shows the structural differences, ICD-10-PCS has 7 characters. And unlike ICD-10-CM, where the length of the code can be variable, ICD-10-PCS codes all have exactly 7 characters. Any character can be either alpha or numeric. The letters I and O are not used in order to not be confused with the digits 1 and 0. So 1 and 0 are used in ICD-10-PCS, but I and 0 are not. Again, the alpha characters are not the case sensitive. And as I mentioned, each code must have 7 characters. If it's missing a character, then it's invalid. So this next slide shows you a pictorial of the differences in how an ICD-9-CM procedure code looks versus how an ICD-10-PCS code looks. So on the next slide, there is an index, just like we have an ICD-9-CM. But one major difference is the index is sort of like a crutch you use while you're in training, and then when as you become more familiar with ICD-10-PCS, people tend to use the index less. And unlike an ICD-9-CM, where any people with formal coding training know, hey, you must start with the index and then you go to the tabular, in PCS, it's okay to go to the right table, and we're going to take a look at what some of those tables look like. So the index sort of guides you to the correct root operation and the correct code until you're familiar with it. It also provides a lot of the common procedural names in the index, like hysterectomy and appendectomy, which are not used in ICD-10-PCS, to guide you to the appropriate terminology in ICD-10-PCS. It also includes eponyms in PCS to help guide you to the right table, because PCS terminology does not use eponyms. The tabular part of PCS, which we are going to take a look at, is entirely different from ICD-9-CM. It really is a true table. It's a grid with rows and columns that delineate the valid combinations of code characters. So on the next slide here, you will see that there's a real defined structure to the code, and there's a whole number of sections within ICD-10-PCS. We're going to focus on the Med-Surg section today, so just keep in mind that the other sections of PCS have may have some different attributes to the characters, although they'll all still have 7 characters, but their definitions and the things they put in those characters are sometimes a little bit different. But we're going to focus on the Med-Surg section today. So each of the 7 characters has a very well-defined meaning. The first character of the code identifies the section. Sections relate to the type of procedure. For example, the Med-Surg section, the section is always going to be the same because we're going to talk about the Med-Surg section today. But a chest X-ray would be a different type of section because that's an imaging procedure, and so it would have a different section character. The next character is the body system, and then you have root operation, and again this is specific to the Med-Surg. The 2nd through 7th characters may have some different meanings within each section of PCS, but we're focusing on Med-Surg today. The 4th character is the body part. The 5th character is the approach. The 6th character is the device. And the 7th character is the qualifier. Approach refers to the technique used to reach the site of the procedure, such as open or percutaneous. And devices within PCS don't mean devices used to perform the procedure. They refer only to devices that are left at the conclusion of the procedure. And then the qualifier provides additional information about the procedure that essentially isn't contained within one of the other characters. Again, each code must have 7 characters, so the letter Z is used in a character position to indicate that a particular character is not applicable for a specific procedure. And I know this might sound a little bit confusing, but we're going to look at some examples shortly, which will give you a really good idea of how this works. So, next slide. So here is a listing in the next few slides here of the root operations in the Med-Surg section. And I'm not going to read all of these to you today. We'll touch on a couple of them. And this might seem a little overwhelming. And when you read some of them, you might find yourself saying, huh, that doesn't sound like what I would think that word meant. But these definitions are all consistently applied within PCS. So once you understand these root operations and the definitions, they don't change, and they become very easy to use. So for example, bypass is altering the route of passage of the contents of a tubular body part. And that might sound a little strange, but when you think about what a bypass procedure does, that is essentially what it is. And one of the beauties of PCS is the consistent use of standardized definitions, because sometimes terms are used throughout the ICD-9 procedure codes in different ways that are not standardized, adding to confusion about what's really going on. But these all use very standardized root operations with very specific definitions. So examples for this root operation would be coronary artery bypass or colostomy formation. Control is stopping or attempting to stop post-procedural bleeding. So this root operation is only used for post-op hemorrhages. On the next slide, for example, detachment is cutting off all or a portion of the upper or lower extremities. So, for example, a below-the-knee amputation would be considered a detachment in PCS terminology. On the next slide, excision is cutting out or off without replacement a portion of a body part, liver biopsy, partial nephrectomy. Once you think about it, you understand that, and you have to keep in mind that excision and resection are very specific within ICD-10-CM, where excision, or within ICD-10-PCS, I mean, excision is focused on a portion of a body part, and resection, as we'll see in a second, is focused on an entire body part. So on the next slide, fusion, joining together portions of an articular body part, rendering the articular body part immobile. So spinal fusion, for example. And on the next slide, release is freeing a body part from an abnormal physical constraint by cutting or by the use of force. So carpal tunnel release, adhesiolysis would be considered a type of release in PCS. On the next slide, replacement is putting in or on biological or synthetic material that physically takes the place and or the function of all or a portion of a body part. And on the next slide, this is one that you see a lot in trauma because of its use for fracture repairs, and that's reposition. So moving to its normal location or other suitable location, all or a portion of a body part. So that's what a fracture reduction would be called in PCS. So I'm not going to read all the others to you, but these are the slides that outline all of the root operations that are used in the Med-Surg section of PCS. So every single procedure in the Med-Surg section is classified to one of these root operations. We're going to skip the next slide and go to the slide that says suture of artery at the top. And this just gives you kind of an example of the beauty of the specificity within PCS. So in ICD-10-CM, we have one code for suture of artery. You don't know the approach, you don't know whether it was an open or percutaneous. You have no idea what artery it is, but there's just one code. In PCS, there are 195 codes to represent that same concept. And that sounds overwhelming, but really it's just because you have the approach defined as either open percutaneous or percutaneous endoscopic, and then there's 65 different arteries identified within PCS that you can suture. So you can see the possibilities and the specificity of the coding system where you actually know whether you did an open repair of the abdominal aorta versus a percutaneous repair of the radial artery. Two very different procedures when it comes down to severity, complexity, and patient outcomes. So now we're going to look at some PCS coding examples, because the best way to understand PCS is to really look at some examples. So the first one that we're going to look at is a left knee arthroscopy with a repositioning of the anterior cruciate ligament. And I showed you the code there of 0MS P4ZZ. Just keep that in mind for a second. And then we'll go to the next slide. And this is an example of a table within PCS. So the top part, it shows you the section character, the body system, and the operation. And within the PCS system that's available on CMS's website, you can click on the MedSurg section, then you can click on the body system, and then you can click on the root operation and hone right in to this table. So I couldn't really depict that whole process in a slide presentation, but those couple of first steps are done, and this is showing you the final table of how you assign the code. And assigning a code in PCS is like building blocks, essentially, where you're building it a character at a time. So the section for all of these examples we're going to talk about today is going to be 0, because that's the section character for MedSurg. In this case, and the body systems are unique to PCS. So when you look at the body systems, they may not be exactly the same as you learned body systems in anatomy and physiology. They're organized uniquely for PCS. So in this case, the body system is bursa and ligaments. The next character that shows on that top line is the root operation. And so in this case, it's reposition, because you're repositioning a ligament. So it's 0MS, and then you pick the body part character. So it's P for knee, bursa, and ligament left. And then you pick the approach, percutaneous endoscopic. And then it's just ZZ at the end, because there is no device and there's no applicable qualifier. So that's how you get to the code. So let's look at the next one. Closure of abdominal wall stab wound, 0WQF0ZZ. So on the next slide, it shows, again, the table with the section, the body system, which is W in this case, because it's not a specific, because abdominal wall, there is a guide at the beginning of PCS that tells you like where to get to for the different body parts, but this goes to a one known as general anatomical regions. And then this is repair, it's the root operation. So it's 0WQ, and then the body part is F for abdominal wall, and then 0, this is an open procedure, and then ZZ. And an important point to keep in mind is the horizontal lines do have a meaning. So you can't jump between rows. They do define the applicable and relevant values for each of those line items. So that's why you see several body parts, approaches, and then the device and qualifier, and a row divider, a line. You have to stay within the row that you're looking at. So let's look at the next example, closed reduction with percutaneous internal fixation of a right femoral neck fracture, 0QS634Z. So on the next slide, this is a reduction, which I talked about earlier in PCS. A reduction of a fracture is a reposition. So this is in the lower bones body system. The root operation is S for reposition. And then the body part is 6 for right upper femur. And then a 3 for percutaneous, a 4 for internal fixation device, and a Z because there's no qualifier, and that's the value that it gives you in that column. So that's an example of how you get to the code. But you can see where it's easier in a lot of ways to just go to the table and pick out your appropriate values from each of the column rather than start with the alphabetic index like we're used to doing in ICD-10-CM. So the next example is a laparotomy with a suture repair of blunt force duodenal laceration, 0DQ90ZZ. And you'll notice how kind of odd these codes seem, and there's no decimal point, and they're kind of hard to memorize, but you really don't memorize them. The ICD-10-PCS experts that I know, they can look at this code and they can just tell you that what this code says by just breaking down the 7 characters and knowing what the meaning is of each of those characters. And I know that might seem really incredible to you right now, but once you start doing it a lot, it's pretty easy to do. So on the next slide, we're on the root operation repair table in the gastrointestinal body system. So the first 3 characters are 0DQ, and then the body part value is 9 because this is the duodenum, and then this was an open procedure, so it's 0 for open, and then ZZ again because there is no particular device or qualifier value for this particular procedure. So now we're going to do a couple of case examples where we show both the 10-CM and the 10-PCS codes. So in this first one, it's a 35-year-old male who fell from a ladder. The diagnosis is an open fracture of the left elbow, specifically the olecranon process, and a dislocation of the left wrist, radiocarpal joint. The procedure is an open reduction, internal fixation of the fracture with debridement and manipulation of the dislocation. And just so you know, we're not going to do the external cause codes in these examples. I know you're going to have other training on those. So these examples are just going to focus on the diagnosis and procedure codes. So on the next slide, the diagnosis code is going to be F52.022B, displaced fracture of the olecranon process without intra-articular extension of the left ulna, initial encounter for open fracture type 1 or 2. And I don't know if I showed this in one of the earlier slides, but open fracture type 1 or 2 is shown in the ICD-10-CM classification system as the default if the Gastilla open fracture type is not documented. And I didn't show you all the steps in the alphabetic index with this one, but basically you would look it up just like I did earlier. So again, just you would look up the fracture of the olecranon process, and it's the left ulna. But you can see how specific and detailed this particular code description is compared to some of the ICD-9 codes that we have today. The second diagnosis is S63.025A, dislocation of radiocarpal joint of left wrist, initial encounter. And again, I forgot to mention, we coded this as displaced because, as I mentioned earlier, a fracture not indicated as displaced or non-displaced is coded as displaced. So let's take a look at the procedural coding for a second. So this is a fracture reduction. That'll be the first one we do. So it's a reposition. So in its upper bones is the body system. So it's 0 PS. And then the body part is L because it's the left ulna. So it's a reposition of the left ulna. It's an open approach, so it's 0. And there was internal fixation device, so it's 4. And then the final character is Z because there's no qualifier. Remember, reduction of a displaced fracture is coded to the root operation reposition. Debridement is not coded separately with a fracture reduction unless the physician documents that a separate debridement was done that wasn't just part of cleaning the wound. So now we're going to code the dislocation repositioning. So again, we have the reposition is the root operation. This time we're in the upper joints as the body system. So it's 0 RS. P is the body part because it's the left wrist joint. And in this case, we hadn't really talked about the definitions of all the approaches. All of the approaches in PCS have very specific definitions, just like the root operations do. An external approach is a procedure that's performed directly on the skin or mucous membrane, and procedures that are performed indirectly by the application of external force through the skin or mucous membrane. So this is why it would be an external approach for this particular one. So we have a code of 0 RS PX ZZ. The X again is for the external approach, and there was no fixation device for this particular procedure. So on the next slide, this just summarizes the two procedure codes. So we have 0PSL04Z, repositioning of the left ulna with internal fixation device, open approach, and 0RS PXZZ for repositioning the left wrist joint external approach. And I know this probably seems really kind of overwhelming right now, but trust me, when you really start working with PCS and assigning these codes and these tables, it becomes easier and easier. You know these definitions off the top of your head. You can hone right in to the code that you're looking for. So we're going to do a second example. 25-year-old female involved in a motor vehicle accident. The diagnosis is a liver injury without mention of open wound in the cavity, multiple grade 3 hepatic lacerations, predominantly involving the posterior segment of the right hepatic lobe as well as the caudate lobe. There is also an occipital scalp hematoma, a subconjunctival hemorrhage of the right eye, and a 1 centimeter laceration of the left forearm involving the skin and subcutaneous tissue. And I've given you the GLASGOW COMA scale there too upon arrival to the ED of 4, 5, and 6. And the procedure was a suture of the forearm laceration. So on the next slide, here's the coding of the diagnoses. So S36.116A, major laceration of liver initial encounter. And you might wonder, well, how did I get to major laceration? The major laceration definition, according to the inclusion note under the S36 codes, indicates that a major laceration essentially equates to a grade 3. A laceration with significant disruption of the hepatic parenchyma, greater than 10 centimeters long and 3 centimeters deep, is how it's defined in ICD-10-CM. And this major laceration also includes multiple moderate lacerations. So when you look at what a grade 3 is and how a major laceration appears to be defined within ICD-10-CM, it appears that they would equate to one another. A hematoma of the scalp is classified to a contusion. So the next code is S00.03XA. You need the placeholder X in order to append the 7th character A for the initial encounter, and that would be contusion of the scalp. H11.31, conjunctival hemorrhage of the right eye. Subconjunctival hemorrhage, per the alphabetic index entries, is classified to conjunctival. S51.812A is laceration without foreign body of the left forearm. And there's the 3 codes that equate to the GLASGOW COMA scale. Again, when you have the individual scores, you code them and not the code in ICD-10-CM for the total score. The 7th character indicates when the scale was recorded. In this case, the documentation said upon arrival to the ED. This next slide shows how to get to the procedure code. Again, this was a repair of a laceration on the left forearm. So repair is the root operation. The body system is subcutaneous tissue and fascia. So it's 0JQ. The body part is H for subcutaneous tissue and fascia of the left lower arm. It was open, 0, because it's already open because it's a laceration, and then ZZ because there is no device or qualifier. So the next slide shows you the final procedure code. 0JQH0ZZ, repair subcutaneous tissue and fascia of the left lower arm open. And that's the conclusion of my formal presentation. So I would be happy to take any questions right now, unless I've so overwhelmed all of you that you're completely speechless. But if you have any questions, I would be happy to answer them.
Thank you very much, Sue. We do actually have a couple of questions that came in during your presentation, and I'll start with a few of them now. What if it is a burn injury that requires multiple grafting well after the acute treatment, sometimes over a month or so?
Typically, and if we start getting into really detailed questions, it might be hard for me to answer them on the fly, but typically if it's all really part of the initial care of the burn itself, it would still be considered an initial encounter. It might move into more of a subsequent encounter when it starts getting into more repairing the scars or dealing with cosmetic issues or that kind of thing. But as long as it's really considered part of the initial care of the burn, there is no time limit. And I should have mentioned that. That's a really good question. There is no particular time limit on the use of the initial encounter seventh character. It's really based on whether it's still within the phase, I guess you would call it, of actively caring for the acute injury itself.
Okay, the next question is, many times external fixators are removed during a patient's initial stay in the hospital. Would this go in as a subsequent encounter?
Could you repeat that again? It broke up a little halfway through your question.
You know what, so I'm going to have to get back to it because it just disappeared. I apologize from our
I didn't catch some of it, so
okay.
It sounded like
we'll
okay,
get it back later in the question session. The next one is, how would we code healing fractures identified on pediatric patients who come in with suspected abuse?
It would that gets into where it's somewhat of a judgment call. It would probably depend on how the physician described the fracture. If it is recent and he plans to, treat it, then I would probably code it as initial still. If it's more like older fracture, is just documenting that they're there and that they're in the healing phase. The problem you get into with some of those issues with the type of encounter is you don't necessarily know if the patient had seen a provider before for the fracture at all, or if this is a different provider, whether they had any care for the fracture or not. But if there is no particular documentation about the treatment of the fracture, but no real focus on treating the fracture seems to be taking place, and he is sort of describing it as older or just almost healed or something like that, then I would probably consider it in the subsequent encounter category. But that can be a tough one depending on the documentation.
Okay, back to our previous question. The question was, many times external fixators are removed during patient's initial stay in the hospital. Would this go in as a subsequent encounter?
No, and that's a really good question because that I didn't get into is a lot of different things can happen during the initial hospitalization, but essentially, and this is an important point, you can't go back and forth between initial encounter and subsequent encounter. So essentially, everything that goes on within the initial hospitalization is still going to be considered part of that initial encounter because you sort of have to think of it as the phase of the fracture or the injury, and they're still in that active phase. Plus, it would all be on an inpatient claim, and you wouldn't have some codes on the same claim with an initial encounter seventh character and other codes on the same claim with a subsequent encounter seventh character. That just shouldn't happen.
Okay, thank you. The next question is, what about readmission for the same injury?
A readmission for the same injury, assuming they're still, it's not like aftercare where they're taking the fixation device out or something like that. That would still be considered part of the initial encounter. So if they come back and they're having more surgery, that would still be part of the initial encounter. I should mention, too, that the definition of the encounter goes with the code. So what I mean by that is if you get an infection related to an injury, and now the code that's on the current encounter is the infection code, we've had some questions about, well, is that a subsequent encounter for the injury? But you have to focus the type of encounter on the actual code itself, and the code you're assigning at that point is the infection code, and so it's initial encounter for the infection, if that makes sense. You can't relate it to a code that you're not appending the 7th character to. It relates to the phase of care for that particular code that's being assigned.
Okay. Regarding procedures, will the tables be available as a reference for all procedures?
Yes, and as a matter of fact, I mean, there's a lot of codebook vendors that have PCS out there already, but to tell you the truth, the PCS system that is on CMS's website, which is free, is very easy to use and has everything hyperlinked and has all the definitions of the approaches and the root operations and everything right there. So you can hyperlink from the root operation to the body part and move around that way, and it's really easy to use, and it's the entire system. So I actually find it very easy just to use the CMS PCS system.
Okay. Can you please give an example of a qualifier?
A qualifier. Trying to think of an injury example. Well, the one I can think of a lot of times is it's just additional pieces of information that couldn't be fit into one of the other characters. So I know, for example, in a coronary artery bypass, they use a qualifier to identify the other artery involved in the bypass. So they use it for little pieces of information like that. I'll try to see if I can think of another one, but there's some very unique information. They're also using it for additional information about devices and that kind of thing. I think there might be qualifiers perhaps related to the bearing surfaces used in hip joint replacements and that kind of thing.
Okay, the next question is, do you think that the M80 osteoporosis codes will eliminate many hip fractures from the trauma registry?
That's possible. There is an ICD-9 coding guideline today that encourages the use of the pathological fracture codes instead of the trauma codes if the trauma was so minor that it typically would not involve a traumatic fracture code. But in ICD-10-CM, it does make that process a little bit easier in that it links the osteoporosis and the fracture together. So it might be easier for people to more consistently follow the process for what's a pathological fracture versus what's a traumatic fracture. So from that standpoint, that is possible. The rules per se aren't that different between the two code sets.
Okay, the next question, I don't know if you're able to answer this, but do you know if all the major registry software providers are set for the 2015 implementation of ICD-10?
That is a good question, and no, I do not know the answer to that.
Right.
Out of all the people I've heard talking about who's not ready and who is ready, I have to say no one has brought to my attention that they won't be ready. I don't know if that's a good indication or not, but
okay. What code would you assign for a wound vac?
That I would really have to look up, and my email address is at the end, so you could send that to me, and if I can't find it readily, we can send it into Coding Clinic, but off the top of my head, I'm not sure.
Okay. All right, I do, Sue, I want to take this time to thank you very much for joining us today. For folks that had some remaining questions or any more specific questions, you can please feel free to email Sue or please address your questions by logging into the ATS website's Trauma Registry group, which is available to you. We have registry experts and faculty available to answer questions or concerns. For your information, this webinar is recorded and will be available for viewing on the ATS website later this week if you need to refer back to any of the content that was discussed today. On behalf of the ATS, I would like to take this opportunity to thank Sue Bowman from AHIMA for today's outstanding presentation, as well as Garrett Hall from our ATS Trauma Data and Registry Council for coordinating today's session. Please be sure to check the ATS calendar for additional registry educational webinars coming this summer and fall. Again, thank you for joining us today, and have a pleasant afternoon.